Hello, everyone. It's exciting for me to be here today with my good friend, Dr. Karl Stonecipher. I'm Cathy McCabe. I'm on the west coast of Florida, where I'm a cataract and refractive surgeon.
I am in Greensboro, North Carolina. We're in lovely Hawaii right now, so if you're wondering about where we are. But I do both academic and private practice, so I do a lot of LASIK and a lot of cataract surgery, but I'm also on staff at the University of North Carolina and at Tulane.
Awesome. Always great to be here in Hawaii with you,
Always
Karl.
great to see you as well. So what are you talking about today?
So we're going to talk about IOLs
Okay.
and different materials and lens design and how that impacts our choices and how we take care of patients.
So what are you using today? What kind of lenses? Give me for instance.
So I really use all the different lens platforms. I think that there's a role for all the different ones and different patient expectations along with the physiology of their eye and what we're anticipating in the future. You know, there are certain lens designs where we think maybe we'll have to either reconsider having that lens for the patient. Some of them we know that we take out again if it's not right for the patient. And, you know, what are the risks of it being something that's going to last the lifetime of the patient?
Yeah, and you and I've been through a lot of lenses, so lens design is important. I think lens material I think is important. Lens haptics I think we'll talk about today a little bit are important. But I think for me, a lot of people get all bugabooed about posterior capsule opacification stuff. Where are you in terms of that? I mean, do you really look at a lens and say what's the rate of opacification that influences whether you're going to use an acrylic lens or maybe a silicone or something else?
Yeah, so, and that's a great question because for patients, having posterior capsular opacification is a big deal, right? Because they can't see as well. They feel like their cataract's coming back. It decreases quality of vision. So we like to think about lens designs that have done things in order to decrease PCO rate, such as modified the edge of the lens and certain lens materials. So sharp edge design, especially on the posterior aspect of the edge of the lens, we know really decreases the ability of lens epithelial cells to migrate, and so decreases PCO rates, which I think is great. That's been a nice change that we've seen, and really we've had that for a long time now. And also I did for a long time put in a hydrophilic acrylic. We know that those have a little bit higher rate of PCO. But the good news is with all PCO, we can treat it with YAG capsulotomy, and that really makes a big difference for patients.
Yeah, and I'd always kind of look, like the hydrophilics. So I'd put a bunch of those in, and a lot of those people would come back later. I mean, they wouldn't come back like you would think. I mean, they'd come back 3 or 4 years later, and they'd have this amazing posterior capsular opacification, but they were totally functional. And you're like, you don't have any glare, halos at night. So I think with hydrophilic, I worry about, are they going to get silicone oil? Are there other things that we're going to run into? Fuchs dystrophy, and we're going to do endothelial cell transplantation or something. So materials, hydrophilicity matter. The latest that I use a lot of is the Rayner EMV. I like the fact that it's got a high Abbey value. You can see real well through it. And in the clinical trials, posterior capsular opacification wasn't a real huge thing as a hydrophilic. The hydrophobic, I think, the new Clarion lens, there's some anterior capsular opacification you can get as well as posterior capsular opacification. Have you seen that or no?
So yeah, for me, I'm one of those OCD surgeons, as I know you are, many of us are, and it kind of started with my crystal lens experience that I really was paying a lot of attention to removing as many of the lens epithelial cells as I could. So I kind of have a 3-stage process for that. I do a little what I call power washing with BSS on a syringe, making sure I hold, of course, the hub of the needle so we don't create a missile in there. And I do that. I make sure that I have very complete cortical removal. And then I actually take a polisher and I polish the underside of the anterior capsular leaflet. And I go back and I power wash again. So I'm pretty meticulous about that. And maybe that's why I feel like with the Clarion lens, I really haven't seen that anterior capsular phimosis you're talking about, or fibrosis, or opacification. I think that lens actually, and that lens design, which we have long-term experience with the Acrosoft platform, does a good job of decreasing and having very low PCO rates. But I think the other thing, as you mentioned, is this pristine optic that you can get with hydrophilic acrylics too, which is really wonderful. And if the patient does get some PCO, we do have YAG capsulotomy that's available. And that's kind of a plus minus. Like, how do you feel about YAGs?
Well, so if we go back, in terms of different type of lens styles, totally agree with everything you've said. And I think it's all about technique, it's all about technology, and I think various technologies have higher rates. So when you say to me, does it really matter? I have a low threshold to do a posterior capsule. It's easy on me. You don't have to convince me. You just say it affects you, and great. And if you qualify, you pass the test, you glare, whatever, say you're going to get a YAG capsulotomy. I see that more in my younger patients. So I'm doing a lot of those. I've done like 82,000 LASIK. And so those are what are coming back. They said, you made me see once, and so now I want to see again, and love the Vivity lens in that population. And if they come back and just even, it seems like a little bit of posterior capsular opacification can influence what they see. If you're a pilot, or if you're a 5.0 tennis player, or you're a 4 or less handicap golfer, I'm more prone to use one of these acrylics because I think they see a lot better. But you and I had an experience recently where we happened to be with one of our friends who was talking about her personal experience with the YAG laser capsulotomies. And that was kind of completely, I just didn't never think from the other side of the fence what it was like. So for me, I really maybe had a few patients that couldn't really do as well after their YAG laser. I mean, not very many. And I'm not talking about complications like a retinal detachment or CME. I'm just saying that they may have gotten streaks or more halos or something like that. And we've all had that. But the patient was telling us she had 2 different style lenses in, and the difference between that, she really noticed that difference. Have you seen patients like that?
Yeah, I think for me, it highlights an issue that we're going to be talking more and more and more about. And, we have been talking about it for a bit, and that's looking at the quality of vision and looking at it from the aspect of what's the pathway of light. And so we know we can clear up the cornea. We've been doing a lot of work on ocular surface disease for that. We know we can address the lens. We know we can address PCO with a YAG. But what happens posterior to that? And so sometimes it's just that the YAG itself has maybe stirred up some other opacities within the vitreous, not just the pieces of the membrane, and patients are maybe seeing those now. Or what we thought was some of their symptom that was from the PCO actually was a little more posterior to that and was vitreous syneresis. So I think we're going to continue to understand that better and have better tools to deal with it. And as we're trying to achieve the best quality of vision, really looking more posteriorly for that. So it doesn't mean we can't do a PCO treatment with the YAG. We need to clear that part of the pathway too, but that might not be the end of the story.
But the beginning of the next phase of that is, I've done a lot of cataract surgery and I just haven't taken a lot of lenses out. So in my hands, my lenses, I've only taken 2 out. Now, I've seen a lot of other surgeons that give me those patients, like you and I were discussing yesterday, that, they always seem to migrate towards you. And whether that's, to take care of their residual refractive error, take care of their dry eye, but sometimes they've got the wrong lens
for
in
their
the wrong
anatomy.
patient.
Yeah, for their pathology.
Yeah, and you're just like, okay, do I open the capsule? Do I not open the capsule? So how do you deal with that in your practice in terms of you're trying to make that decision, okay, if I really open the capsule, is this person going to be happy? Because if I open the capsule, I'm going to have to struggle if I end up doing an intraocular lens exchange. And I'm sure that comes up.
Yeah, it's so hard because you're not sure when you're talking to the patient, is there glaring halos? Because it's typically in that setting that it becomes confusing, or even quality of vision. Is it because they have some early PCO? Or is it because, the lens itself, the design isn't good or a good match for the patient? And so there are little clues you can get, you want to know if it's fluctuating. That always helps. Were they unhappy immediately after surgery before PCO happened? Was that part of it? But, sometimes we even have fibrosis of the capsule that we couldn't eliminate at the time of surgery. So then you don't get that clue. But if it was something that came on later, that's usually PCO. But I think in the end, sometimes it's just a toss-up, and you have to have a heart-to-heart with the patient saying, look, if you had to have this as it was right after your surgery, would that be a deal breaker for you? Would you be upset? Or are you just hoping for some improvement? Or if you're like, nope, if this is the best it can be, I'm out, I need to do something different. And then you talk about the risks and benefits of that before doing a YAG. If they're like, now let's see what happens with the YAG, realize, and you have to feel comfortable in referring them to somebody else who can still do an IOL exchange. A YAG is not a deal breaker for that. You can do it, and you could do it safely still.
Oh, I agree. And I think that what comes into my head and my personal practice is, I'm going to do things like contact lens trials and say, is that any better? I mean, did that solve your problem? And are we going to do laser vision correction? I think there's a lot of things, like you mentioned, that we can do to help us focus where we need to go. And you say, well, what is a contact lens trial going to do in a person that has posterior capsule opacification? It's going to tell me whether that's significant or not. So a lot of my optometrists do that. And I think that, it's just another way to go. And we're going to treat dry eye disease. If they have postoperative dry eye disease, we're going to try and do everything we can to maintain that capsule. And I tell the patient, I said, it's going to be a harder challenge for me if I take this lens out, and it may influence what lens I can put back in.
Yeah, and so since we're talking about haptics, let's just talk real quickly. Do you ever think about haptic design
All the time.
But as we talk about it with like our premium patients, and if we're thinking, this patient's maybe on the edge of being good for this particular design, maybe it's a diffractive optic or something, and they have a little bit of concern about glare and halos, and there's a small chance you're going to want to take that out. How much does haptic design really come into your thought process about that?
Let's start on the first end. I still use the lenses, but when the haptics kiss and hang on to each other, that's always frustrating. It's just another thing. You can, take a pair of capsule forceps or something and help it go away, but when you're trying to go through a list, it's a little bit aggravating, I guess I would say. But so that's a more sticky haptic, and a lot of patients now are getting these lenses that are torics, that are more sticky haptics, so they don't rotate, and we don't have to worry about rotational loss of correction or loss of power. So I think that, yes, haptic design is important to me. And do I not use a lens for that? No. But if I'm doing an intraocular lens exchange, yeah, I'm sitting there thinking, okay, what lens do they have in? Might I have to leave the haptic behind? And I don't have a problem with that. There's a lot of surgeons like, I got to get it all out, and I'm not going to leave it behind, or the referring physician is going to see it and think that I didn't do my job. I'm like, no, I just, I do a very simple technique. I elevate the lens with viscoelastic, and before I remove it, I put my other lens underneath it, and then I let that kind of stretch into place and either fit where the old haptics were, are in a new spot. And last week I did one from a referring physician where I had one bag in and one haptic in the bag and one out of the bag. And then I had to kind of work, how can I get that other part of the bag open, because it's been several months since they had their surgery. So, that comes into my play, but I don't do the light adjustable lens, but you have talked to me about it's a little harder lens maybe to take out. But I think what that haptic design says to me is I've got to be diligent with that patient early on. That's not a patient that I want to see at 1 day and 3 months and say, oh, wow, we got a problem now.
Right. So sometimes that lens design, or even how much fibrosis you see, may influence how long you're willing to hold the hand of the patient too, before you decide, maybe this is going to be a no-go for that patient. It does for me anyway. I'm like, how long is it that we're going to be best buddies before I go, you're right, you're not happy with this, and I'm going to do something different.
Well, and I think when we're talking about YAG lasers, the whole point is we're trying to make the patient better. Now, there's a risk profile, but for me, it's pretty minimal. I mean, I can't say I've seen tons of retinal detachments or tons of CME with today's, medicines that we use, or whatever you want to say, in terms of looking at patients beforehand and making sure they don't have any little holes or tears. And we now have these devices where you can see, out to the aura, and you don't even have to dilate the patient. So I think there's a lot of strategies we have to prevent problems. But it was really interesting, going back to the comment about this one patient, that it really affected her quality, like you were talking about vision. So, it makes me think about, why am I doing it? What am I doing it for? And what outcome do I expect?
And then what are you going to do if you don't get the outcome you expect?
Right.
So I think sometimes it's almost diagnostic, right, between the potential sources of displeasure for the patient, or their sources of decrease in quality of vision.
And now I'm going to add, am I going to create a new dysphotopsia? But, the point is I don't think that's very common.
And we have ways of dealing with it if we get it.
Yeah.
Awesome. Yeah. Always great talking with you about any of these subjects.
Appreciate it.